space. For you to obtain an opening cerebrospinal pressure, the patient must be in the lateral recumbent position. Use a flexible connector and attach a manometer to the hub of the spinal needle. After waiting for the column of fluid to rise and possibly seeing pulsation from cardiac or respiratory motion, you may take a measurement. If the cerebral spinal fluid pressure exceeds 25 centimeters of water, you should closely monitor the patient for signs of herniation and determine the cause of the patient's elevated intracranial pressure. You must allow cerebrospinal fluid to drip into the collection tubes. Never aspirate cerebrospinal fluid. Even a small amount of negative pressure can precipitate a hemorrhage. The amount of fluid collected should be limited to the smallest volume necessary for testing. Typically, 3 to 4 milliliters of fluid is sufficient for routine indications. By turning the stopcock toward the patient, fluid in the manometer may be collected. After collecting an adequate specimen, replace the stylet and remove the needle. Although traditionally patients have been told to lie flat for several hours after a lumbar puncture, there is no evidence that this precaution decreases the risk of a cerebrospinal fluid leak, post-puncture headache, or other complications. All sharps should be properly disposed of in appropriate sharps containers or needle lock devices to help minimize the risk of needle stick injury. Obese patients may represent a challenge due to difficulty in identifying landmarks. Other conditions, such as osteoarthritis, ankylosing spondylitis, kyphoscoliosis, previous surgery that has altered landmarks or spaces, and degenerative disc disease also may make the procedure more difficult. If faced with these challenges, consider consultation with an anesthesiologist or perhaps a radiologist, if fluoroscopy-guided lumbar puncture seems to be a better approach. Lumbar puncture has numerous possible complications, including cerebellar herniation, referred pain, headache, bleeding, infection, the formation of a subarachnoid epidermal cyst, and leakage of spinal fluid. You can avoid many of these complications by conducting a careful assessment of the patient before the procedure, including a thorough neurologic examination and retinoscopy, and monitoring the patient throughout the procedure. A subarachnoid epidermal cyst occurs when a skin plug is introduced into the subarachnoid space. The standard use of a needle with a stylet will avoid this complication. Leakage of spinal fluid can occur at the puncture site. A large bore spinal needle is more likely than a smaller bore needle to produce a leak, so the latter should be used whenever possible. In the case of persistent leakage of spinal fluid, an anesthesiologist should be consulted to determine whether a blood patch is needed to occlude the leak. Lumbar puncture is a commonly performed procedure that can be a very useful aid in clinical diagnosis and treatment.